Muy buenos días tengan todos ustedes. Sean bienvenidos a nuestra masterclass el día de hoy. Como ya sabemos, hoy tenemos una invitada muy especial, es la doctora Ana Fagotti. Como ustedes ya conocen, y creo que no necesito dar más introducción a la doctora Fagotti. Ella es una autoridad mundial en cáncer de ovario. Y el día de hoy nos hablará justamente de los predictores de resecabilidad en esta neoplasia.
So, good afternoon or good morning actually in your country. Good morning everyone, and thank you very much for this kind invitation. It's really an honor for me to be with you today. So the objective of my presentation, as Dr. Cantu said, is the prediction of primary cytoreduction in advanced ovarian cancer. This is the agenda. We will start discussing the state of the art of neoadjuvant chemotherapy in advanced ovarian cancer patients, a possible algorithm to predict primary debulking surgery in our patients. I will show you a video on staging laparoscopy and how we use the score to predict resectability. Then I will show you the results of the Scorpion trial and what we are doing and what we have achieved after the Scorpion trial. Then we can discuss new possible indications to neoadjuvant chemotherapy and finally conclusions. Of course, feel free to interrupt me or make questions whenever you want. I will be very happy to discuss with you. So the first point is state of the art of neoadjuvant chemotherapy. And you probably know this paper, which was published 2 years ago. This is a review regarding the last and the only randomized controlled trial investigating and comparing neoadjuvant chemotherapy followed by interval debulking surgery with respect to primary debulking surgery in advanced epithelial ovarian cancer. And of course, I don't want to enter into the details of each study or discuss limitations of each study, but I would like to focus with you on what is common from different studies. And what we find is that actually, neoadjuvant chemotherapy is not inferior to primary debulking surgery, or the non-inferiority is not confirmed, or neoadjuvant chemotherapy is not superior to primary debulking surgery, which means, in other words, that there is no difference among these two treatments. And so, in other words, we could say that each patient has according to the inclusion criteria of each study, could be a possible candidate for neoadjuvant chemotherapy. I would also like to underline the complications rate, which in each study was higher in the group of PDS with respect to interval debulking surgery, even though in none of the previous study, this was a primary endpoint as in the Scorpion trial, as you can see here. Of course, we are still waiting for the results of the TRUST trial. This is the state of the art, at least in the United States, as you can see here. If we look at the whole cohort of patients with high-grade serous ovarian cancer, more than 4,000 women, you see that there is a very clear trend to increase the use of neoadjuvant chemotherapy. And if we divide patients according to stage or age, you see that even though this is much visible in the stage 4 disease or in the old patients, you see that it is also increasing in stage 3 and also in young patients, even though with a difference in terms of significance, but the trend is still here. So now, what could be a possible algorithm to predict primary debulking surgery, and I would say complete resection at time of primary debulking surgery in advanced epithelial ovarian cancer patients? But First of all, we can use some screening from the preoperative evaluation to the intraoperative evaluation. And so we have some patients that can be excluded mainly for frailty. Now, the term frailty might be quite general. In our experience as surgeons, we would say that frail are all those patients who are not able to survive to our surgery and what our surgery means. But let's go in the details because several studies have been published on this topic. This is a study from the United States, and here the authors show that frailty affects postoperative outcomes in ovarian cancer patients, such as it increases the rate of 90-day readmission and mortality. And I would say that it also affects the cost of treatment of these patients. And on the right side, you see a study from the French group where you see that patients are divided according to age mainly. So in this case, we are only considering the chronologic age. And you see here they are divided according to surgical complexity score and residual disease. And you see that the older are the patients and the lower is the rate of high complexity surgery and the higher is the rate of residual disease. In other words, it seems that the surgeon, him or herself, decides to have a less aggressive approach in older patients, thus leaving more residual disease. This is our experience we did some years ago, and we were trying to find an objective way to define frail patients. And we decided to use the biodivided phase angle. What is this? This is a simple way to measure the health status of the tissues, which is an indirect way to measure frailty. In other words, this is like this is an instrument that can be used either by the doctor or by the nurses at the bedside, where we use like some kind of energy, electricity, which pass through let's say one finger. And we can measure the composition of the tissue. And this composition is actually related to the status of the cellular membranes and the presence of fat or whatever, which is indirectly related to the status of the patient. And here you see that we found that this bio-derived phase angle was associated with residual disease as well at time of primary surgery, as well as the rate of 90 days complications. Of course, this was not the only one. You see the multivariate analysis, but also the score, which means the extent of disease, was obviously associated with residual disease, as well as with the risk of postoperative complications. And these are two other studies, I think, quite important, showing that frailty is associated again with a higher risk of postoperative complications from grade 3 on and with shorter overall survival. You see here how different is the median overall survival between non-frail or frail and non-frail patients. And on the other side, this is a very recently published paper from the Memorial Sloan Kettering, where you see that more frail patients are less likely to have primary debulking surgery, but also they have a delay in postoperative chemotherapy, and they are less likely to be enrolled in research protocols, and of course, they have a poor overall survival. So once we have excluded these patients from surgery, what are the next steps? Who are the others? And here we can also exclude patients intraoperatively due to tumor extent. Now, we have some information regarding tumor extent. This was a pooled analysis of individual patient data from the EORTC and the CHORUS trial, which was published 2 years ago on Lancet Oncology, where the authors actually demonstrated that overall survival is better, or not, even though not statistically significantly, but there was a trend to a longer overall survival in patients with stage 3C disease and metastasis less than 5 centimeters in favor of primary debulking surgery. Whereas for stage 4 disease, here it was clear that neoadjuvant chemotherapy is better than primary debulking surgeries regarding overall survival. This study, which consider only American population, shows again that patients with stage 3 disease can significantly benefit of primary cytoreductive surgery, whereas patients with stage 4 disease have no difference in terms of overall survival if they are treated with primary debulking surgery or neoadjuvant chemotherapy. I like to show you also that, you see, in the first 12 months, patients undergoing primary debulking surgery have a higher risk of death with respect to patients undergoing neoadjuvant chemotherapy, whereas the advantage is shown only after 12 months. We don't know whether this is related to post-operative surgical complications or other reasons. So what we do in our institution, patients are eligible if they have, of course, let's say quite young age, presumed clinical FIGO stage 3 or 4, a good performance status. They are assessed clinically and they undergo a chest and abdominal CT scan, because we want to assess the extension of disease and suppose, at least based on CT scan, to have an idea whether or not this disease is resectable from a surgical point of view. And then all patients undergo a staging laparoscopy, and staging laparoscopy for us is useful to assess the score, which means the extension of disease, and also predict possibly post-operative complications. So now I have the video, and I want to share you again the screen. Just 1 second, please. Sorry. Here. Let me go here. Okay. I hope you can hear me. Doesn't work. Let me try again. It's not working. I will try again to share the screen, okay? Let me see if this works. Okay, now it works. So I want to show you these different pictures you can see by laparoscopy, and then we can discuss together based on the score. You can see here different situations regarding bowel carcinomatosis or mesenteric retraction. As you can see here, you have different ways or pictures. And then you can also assess, for example, the infiltration of the mesocolon. Here, you can see the peritoneal carcinomatosis, very diffused as in this case. In the anti-Trendelenburg position, you can better assess the upper abdominal disease. You see here the right diaphragm. And then you also can assess the posterior part of the right liver, not very easy. You see here the left diaphragm. you see here the stomach and lesser omentum. Here you see the nodules, you see the greater curvature of the stomach, the lesser omentum with the nodules. Okay, again. Then you can also evaluate the spleen, and you can tilt right the patient in order to expose the spleen and see if there is any involvement. You see here nodules on the liver. Again, here, superficial liver metastasis. You can also have the tactile feeling of infiltration at the level of the hepatic hilum, as here, for example. And then you see the stomach again and the gastrocolic ligament. The gastrosplenic ligament here. You can mobilize the omentum. You see the omental cake here again. And then you can also assess the infiltration, for example, of the transverse colon, as here, for example, you see this, the colon seems free, although there is the omentum over, whereas it's not free here, the mesocolon, you see. And then you can also assess other parts of the bowel. Here is the appendix, and here is the right colon, which is attached to the abdominal wall. You see also some nodules on the right colon again. And then you can also assess here the small bowel, and you see there is a loop of the bowel, small bowel, which is infiltrated. Again, here another infiltration with mesenteric retraction of this part. And then we put the patient again in the Trendelenburg position, so we can explore the pelvis. Of course, we all know it's not a problem, but just to have a complete picture. And then here you see the biopsy of the peritoneum. And I like to underline this point because you need to perform a very large biopsy in order to be able to perform any kind of immunohistochemical diagnosis as well as molecular assessment. So I'm back to the presentation. I hope you can see it and go on. So basically what we have found, we usually perform a laparoscopy to our fit patient, which means that once we know that these patients can survive to the complications related to an extensive surgery, and we always start the surgery with a staging laparoscopy. So we assess a score in order to assess this diffusion of disease. And as you can see here, we first assess the presence of small bowel carcinomatosis or mesenteric root retraction. This is not really very frequent, but however, these are the first two steps that we assess before considering the entire distribution of the disease. And the reason is that if we have a small bowel carcinomatosis or a mesenteric root retraction, it's very unlikely that we can achieve complete resection. Then we can assess the presence of peritoneal carcinomatosis, diaphragmatic carcinomatosis, infiltration of the spleen or lesser sac or the stomach, the presence of superficial liver metastasis, omental cake, and the risk of bowel resection, where we never consider the anterior rectal resection, which is usually always part of debulking in ovarian cancer, but we consider only additional bowel resection except for rectal resection, which means transverse colon, right colon, or small bowel. Oh, here was the video. Okay. And what we can do, we can also assess the risk of major postoperative complications based on this score, as you can see here, which means performance status, presence of ascites, levels of CA125, and tumor load. And as you can see here, based on the coefficient here, we gave a different score to each of these variables. And again, the higher score is given to the tumor extent assessed by laparoscopy. And here we have a very simple calculator where we can evaluate the score, and based on this score, there is a risk of postoperative complication. So based on the extension of disease and the risk of postoperative complication, we can decide whether or not this patient can undergo primary debulking surgery with a high chance of complete resection and low risk of postoperative complications. This has been our algorithm for a long period of time, and this is how we designed it and developed the Scorpion trial. So here we have patients who were fit for surgery, who were supposed to be completely resectable, who had a very high laparoscopic score, and they were randomized between primary debulking surgery and adjuvant chemotherapy followed by interval debulking surgery. So this is a special, I would like to underline that this is a special population where the score was really very high. So one might tell you, why did you perform this kind of study in such a difficult group of patients that would be treated with adjuvant chemotherapy anyway? I'm not sure this is true everywhere. First of all, you have to consider that this trial was designed in 2011, which was 10 years ago. So it means that at that time, we were supposed to be able to resect everything. And consider that still today, people are saying that we can't resect everything. So this is not really a matter of how much disease you can resect, but what is the real advantage for these patients to survive or to have a longer overall survival with respect to the others. So what we found in this study is that actually, if we look at the rate of complete or optimal resection, you see that complete resection was much higher in the group of adjuvant chemotherapy and interval debulking surgery with respect to PDS, and this was as expected. And the same, and on the other hand, we had a very high rate of optimal resection in the group of PDS with respect to IDS. But if we consider overall this population, we were able to achieve optimal resection, which means less than 1 centimeter residual disease, both at PDS and at interval debulking surgery, even though the rates were different according to the timing of surgery. And this was also an unexpected findings, because based on the extent of disease, we did not expect to be so good in terms of surgery. On the other side, of course, you see that the surgical complexity score was much higher, was 3, much higher in the group of PDS with respect to interval debulking surgery. And at the same time, the upper abdominal procedures were always performed, I would say, in all cases, except for one where surgery was abandoned with respect to IDS. And of course, the OR time was much longer in the group of PDS with respect to IDS. So these were findings that were more or less unexpected, but these were obtained within a clinical trial where the rate of complete resection was really very high, differently from all the others that were previously published. If we look at the survival results, you will see here there was no difference in terms of progression-free and overall survival in the whole population between the two arms. If we look at the survival based on the residual disease, you see again that residual disease is one of the most important prognostic factors in these patients because complete resection had the best prognosis in terms of progression-free and overall survival. This is the entire population. Here is not divided based on the arm, which means neoadjuvant versus PDS. But if we look the population divided based on both residual tumor and type of treatment, you see that, again, patients with residual disease go worse, and there is no difference between patients having primary debulking surgery or neoadjuvant chemotherapy, and this is shown very well here in this model. Oh, this is another retrospective study that we published recently, where we wanted to compare, this is a retrospective analysis, of course, we wanted to compare the minimal residual disease obtained at primary debulking surgery with complete resection obtained at interval debulking surgery. So in other words, when we perform a staging laparoscopy and we say, yes, I can achieve complete resection, or no, I will never achieve complete resection in this patient because I will have those miliaric carcinomatosis on the small bowel that I cannot resect. At the end, what is better, doing resection anyway or send patient to neoadjuvant chemotherapy? What we found here is that there is no difference in terms of progression-free survival between these two patients, although we found a better overall survival in patients receiving neoadjuvant chemotherapy with respect to patients receiving primary debulking surgery. However, we must admit that here is a selection bias due to the fact that patients who were eligible for interval debulking surgery were those patients who are good responders. So actually, we don't know anything about all those patients who did not achieve interval debulking surgery because they did not respond. And probably these are patients who had the worst prognosis, and we don't know what kind of survival they might have in case of PDS. So going back to the Scorpion trial, another important result was the rate of postoperative major complications, as you can see here. So again, patients undergoing primary debulking surgery had a much higher rate of complications with respect to patients undergoing interval debulking surgery. And this was true both for early complications and late complications. However, I must also admit that most of these complications were related to postoperative pleural effusion, since it was not our policy to put a thoracic drainage immediately anytime we had to perform any kind of diaphragmatic surgery. So most of these cases actually are patients with pleuric effusion who had to who required a thoracic drainage postoperatively. And this is new because this is the quality of life in the Scorpion trial in the entire population based on type of treatment. So this is the RTC Q30, global health status, primary debulking surgery A, interval debulking surgery B, time 0, 3 months, 6 months, and 12 months. And as you can see here, they start the same way. These patients rapidly improve, the ones undergoing neoadjuvant chemotherapy. At the end, after 12 months, they have the same increased quality of life. Now, this trial was completed in 2017, and so after the results, and considering how we today treat our patients, what are the results? So this is our patient population in 2020, ovarian cancer surgery. So these are patients who were admitted for surgery in our institution. You see here the distribution. We have early stages here in green, 20% of the cases, advanced epithelial, 50%. Then we have non-epithelial, 3%, metastatic tumors on the ovaries, and around 20% of recurrences. You see here, these are patients with advanced ovarian cancer. Some of them are treated at time of diagnosis in our institution, but we also receive some of them directly from outside after adjuvant chemotherapy. And you see here the rate of primary debulking surgery among these, and the rate of adjuvant chemotherapy only because they never responded, or receiving then interval debulking surgery. So at the end, this rate were calculated only on the internal population, of course. Here you see the numbers over the time, 2018, 19, and 2020. So you see here the debulking surgery overall, which include both primary advanced ovarian cancer and recurrences. You see here the number seems lower, but we excluded diagnostic laparoscopy. And here you see the early stages. So we had a slight continuous increase of patients referring to our institution. You see here the rate of adjuvant chemotherapy at the end was decreasing over the time. And you see here the residual tumor at time of debulking surgery. Most of the patients, 88%, had complete gross resection, and 97% of them had optimal resection at the end. So again, thanks to this kind of algorithm, we're able to select patients in most of the cases with complete or optimal resection. But it's also very important how we can select patients regarding post-operative complications. You see here all complications we had. These include also grade 1 and grade 2, which is not really very important. And this is the overall number of complications, which is about and if we consider only G3, it's about 20%, but consider that most of the patients have more than one complication. Indeed, if you look at the number of patients, these are 34, which means around 8%, with no G4 or G5. G5 is death. G4 is a problem which lasts forever. You see here the rate of complications over the time has decreased. And we don't have, at least in 2020, we had no post-operative death related to post-operative complications. And this is how and what we do now. So patients are evaluated preoperatively, and some of them are excluded for frailty. Then they are evaluated. Those who arrive to surgery, they are evaluated intraoperatively. Some of them are excluded for tumor extent, and we still use the score, the laparoscopic score, and then we will see what to do with these patients. But those who are not excluded, they undergo primary debulking surgery in case of advanced disease, but it may happen that this is still some early stage. And all these patients are enrolled in some trials. The patients here undergo the OVIPEC-2 trial. The patients here with early stage, they undergo a trial on sentinel nodes in early stage ovarian cancer. Then patients who are excluded for tumor extent, they are assessed for the BRCA status. Patients who are BRCA negative, they undergo a national, let's say, institutional trial, which is called NIRAMUN, where we try to offer these patients the the most aggressive treatment because of their negative BRCA status. So they undergo anyway surgery, since we have demonstrated that it's still possible to receive at least optimal resection in 90% of the cases, even in these patients with high tumor load, as demonstrated by the Scorpion trial, together with IPEC. Whereas the BRCA positive patients, they undergo chemotherapy trial, which is called Nuvola, based with PARP inhibitors, and I will show it in a while. But from these patients are excluded, of course, those patients with absolute criteria of unresectability, because in this case, they would not be included here, and they undergo adjuvant chemotherapy. All patients who have an exceptional response after adjuvant chemotherapy, they can be enrolled in the LANCE trial, you probably know, which is the trial on minimally invasive surgery versus open surgery at time of interval debulking surgery. And these patients can also receive IPEC at time of interval debulking surgery based on the results of the OVIPEC-1 trial. So last point, are there new possible indications for adjuvant chemotherapy? I can just share with you some possible ideas. So you all know that this is the Mayo algorithm to predict surgical morbidity and mortality after primary debulking surgery. This is very easy to apply. You don't need to perform any kind of laparoscopy, but this is a preoperative assessment. So we actually, first of all, try to see whether this algorithm could be applied outside the Mayo Clinic in our own population, and actually it worked. You see, we analyzed around 600 patients, and you see here most of them actually were appropriately triaged, but there were some patients still at high risk, and these patients have a significantly higher risk of 90-day mortality, as you can see here. You also see that the patients at high risk have a higher rate of mortality in case they develop any kind of complication, which means that patients appropriately triaged, even though they have an important post-operative complication, they can still survive. Those patients who are at risk, if they have a post-operative complications, they have not the resources probably to survive to these complications, as you can see here. And finally, if these patients need a high surgical complexity score, they have a higher rate of mortality if they are at high risk. So what we found is also that if we could try, and this is something that we want to submit to the SGO this year, we found that those patients, if we compare patients at high risk who receive primary debulking surgery and patients at high risk who receive adjuvant chemotherapy, and then they have an improved triage after adjuvant chemotherapy, you see that we are able to decrease, even though this was not statistically significant, but however, we are able to decrease the risk of 30-day post-operative complications, and we are able to decrease the 90-day mortality. Of course, the type of surgery will be easier, the operative time will be shorter, the residual disease will be complete in the second group after adjuvant chemotherapy, and the length of hospital stay will be shorter. So in other words, what we are trying to demonstrate is that in those patients who are at high risk for several reasons, including chronologic age, neoadjuvant chemotherapy may represent the best way for rehabilitation before surgery. So yes, of course, we can provide optimal nutrition or physical exercise or psychological support, but consider that neoadjuvant chemotherapy is the real and most effective way to recover patients and transforming patients at high risk to patients at low risk for surgery. Another option is that patients, based on their BRCA status, are able to have a different response to chemotherapy. As you can see here, these patients actually with BRCA mutations have a high rate of complete response or objective response with respect to no mutation non-carriers. And again, if we look at the histopathological response, it's much higher in the BRCA carriers than in BRCA wild type. And also in our population, where we tested the somatic BRCA mutation, you see here that among the whole population undergoing neoadjuvant chemotherapy, those patients who were not able to achieve or to reach interval debulking surgery due to their their progression or stable disease under neoadjuvant chemotherapy, most of them, 90% of them, were BRCA wild type. So it seems that although we may have several different situations, however, it seems that the BRCA status can be a driver or a signature to identify patients with lower chance to respond to neoadjuvant chemotherapy. This is the Nuvola trial. So what we are trying to do today is that in those patients who are considered unresectable based on our algorithm, who are BRCA mutated, they receive neoadjuvant chemotherapy, including olaparib, and then they undergo interval debulking surgery. The main objective of this study is to demonstrate an increase in pathological complete response with respect to the general population as reported in the literature. And we are still enrolling patients, so we will see the results. Another opportunity is that today, thanks to radiomics, so we can map the heterogeneity of ovarian cancer. And so based on this mapping, we can predict response to chemotherapy and survival. As you can see here, we have two different tumors, both mesenchymal subtype, that, as you know, is the subtype with the worst prognosis, but this mesenchymal subtype has 69 months of survival, and this other has 10 months of survival. And you see here how much more heterogeneous is this tumor with respect to the other. So in other words, can we imagine to offer to these patients surgery, and these patients probably some kind of treatments? And as you can see here, in the same lesion, we can also define the energy, so the so-called cold lesions with respect to hot lesions who have a different response to chemotherapy or, for example, immunotherapy. So in conclusion, I want to share with you two last slides. This has been published very recently, but you probably know the previous results that were published on the same journal in 2020. So this is the situation today. United States, around 20,000 patients, stage 3 and 4 ovarian cancer from the same US cancer programs. But in this group, there was an increase in the use of neoadjuvant chemotherapy from, let's say, 22% in these 5 years with respect to 42% in these 5 years. And other patients from other US cancer programs where there was a slightly increase in the use of neoadjuvant chemotherapy during the same time from 20 to 22%. But if you look at the increase in terms of median overall survival, you will see that here you have from 31.6 to 37.9 months, and here from 31.4 to 36.8. So no difference independently from the use of neoadjuvant chemotherapy, which was assessed based on algorithms or used in the different institutions. And this is, of course, the TRUST trial. I want to remember this because this is the last, probably, and we hope the last trial on the role of neoadjuvant chemotherapy versus primary debulking surgery in advanced ovarian cancer patients. And we are waiting now. I know the enrollment has been completed, and I think that we are waiting for the results in 2024. So, in conclusion, we can say that available data today suggests that the proper indication to neoadjuvant chemotherapy is able to offer a good prognosis and quality of life to ovarian cancer patients with extensive disease. That the results from the TRUST trial will provide additional information on standard primary approach. But I would also say that today, molecular and genetic information will change the landscape of treatment of primary advanced ovarian cancer patients, including indications for primary debulking surgery. Let me just show you this, which is our European meeting, which will take place next week, starting from Saturday. So you are also all invited because we have also an hybrid registration. And thank you very much for your kind invitation. Thanks a lot.
Thank you, Anna. It was a great presentation.
Thank you.
We have several questions from the audience. One question from Argentina, from our friend Florencia. She asked, do you consider that the retraction of the mesentery without macroscopic lesions could be a contraindication for PDS, primary debulking surgery?
I think so. I mean, a retraction of the mesentery can be assessed either by imaging or sometimes by laparoscopy. But if there is a retraction, there must be a reason. So even though I don't see any kind of disease on the peritoneum or on the mesentery, there must be a disease in the retroperitoneal space. So I would say yes, if it's at the root of the mesentery, I suppose there is a retroperitoneal disease.
And therefore, that could be considered a contraindication for these type of surgeries, right?
Yes, if it's like this, yes.
And I have a question about the laparoscopy that you perform. Do you do it and immediately after you do the open surgery, or wait for a second time or another time for programming the surgery?
No, we do at the same time, but I must acknowledge that each place is differently organized. So actually there is no reason to do immediately or after. Do as you are used to do. I know there are some OR which have fixed time, scheduled time for surgery, so there is no problem if you stop and then you perform or decide to perform surgery immediately after 2 or 3 days or after 1 week. No problem at all. You may also have the definitive histology, which can help you in the decision, of course.
I know that you don't use any other prognostic index but yours. Do you consider others, or do you recommend, or may you recommend other kind of index to use?
Are you referring to the PCI specifically? Yes. So actually now we are forced to use the PCI because since we are participating into the OVIPEC-2 trial, we need to perform the PCI. So actually, I think there is not much difference. I mean, this is much more complex, in my opinion, than the simple laparoscopic score that we use. I don't have any problem to use one or the others. I mean, at the end, we want to have a score and to have some ways to define how extensive is the disease. So everyone is fine for me.
So it depends on what do I or anyone is used to use, right?
Yes, correct.
One thing that worried me a little bit was the fragility of patients. You mentioned that many times. The fragile people, they are more prone to have neoadjuvant chemotherapy. Mm-hmm. And you showed us some indexes about this. Is it necessary always to take all these not very young people or not in good shape to take them into neoadjuvant chemotherapy?
What do you mean? I don't understand the question. Is it?
What I'm trying to say is that fragile patients are we have many problems in deciding who to take into surgery or to take into neoadjuvant chemotherapy. Mm-hmm. You mentioned that many times, that all these patients must go to neoadjuvant chemotherapy. In your opinion, are these indexes need to be used in order to differentiate patients able to more likely to go into surgery or to neoadjuvant chemotherapy?
You know, this is a very important question in my mind because I was making the same question to myself during this presentation, because at the end, if you are an experienced, not only surgeon, but just, if you are used to treat with these patients, you feel and you see the patient and you know if this is the patient who can receive surgery or not. And it always depends also from the balance of what surgery they need and how the patients are. So it's not only a matter of numbers, let's say number for fragility score, number for extension of disease, but it's how these numbers match each other, So in conclusion, I would say that there is not always a need to perform the score, even though in difficult situation, when you don't know what to do, they can help you in the decision.
Okay, yeah, for sure. And with the results of the Scorpion and the other studies that are going on, do you think that PDS will be abandoned eventually, or we have to use all these scores in order to decide who to take into surgery or not?
Yeah, I mean, my conclusions were made in such a way just to answer to this question, because I don't think that at the end we will have new information or such different information based on the TRUST trial, because I think that those patients who need, let's say, standard surgery, and in my mind, standard surgery is not only hysterectomy and bilateral salpingo-oophorectomy, but let's say peritoneal cytoreduction. I think they can easily achieve complete cytoreduction without big problems, because today's surgery is different from the past, and we are able to recover patients better and better with not really big problems. So what we need to do is actually to identify those patients who will have problems with surgery. Otherwise, it's feasible, and we don't need to be afraid of doing such kind of surgery. That's my opinion.
Of course. One question from the audience, from our friends in Guatemala. They are asking us that it's not very common that in all these studies, the number of patients that do not finish chemotherapy after surgery, they are not mentioned. Because they say that some patients do not complete the complete treatment after the surgery because of complications and everything. What is your opinion about that?
That is true, actually. As well, it's true that in all trials, only good patients are included, not only for surgery, but also for chemotherapy. So actually, sometimes when you go in the real life, you will have different results with respect to the trials, whatever you consider in the trial, even the PARP inhibitors and so on. Having said that, this was true mainly in the past. I mean that in the previous trials, we couldn't find these numbers, but currently these numbers are reported because there is much more attention to these patients than in the past. So you can find these numbers in our trial, but also, for example, if you look at the Lion trial, we find the same numbers, and we find the reports not only regarding the first 30 days, but also regarding the 90 days after surgery. So I think that today we may have more information than in the past, even from these trials.
Yeah. And another question from the audience: what do you think of laparoscopy after neoadjuvant chemotherapy? Is it necessary, or shall we just go for open surgery and try to debulk the patient?
It depends, of course, from your selection criteria for interval debulking surgery. We use it very much for two reasons. First, because we think that after three or four cycles, we should always consider interval debulking surgery, because we know that these patients have a better prognosis if we can achieve complete resection at this time than without doing it. And so sometimes we also force the indications, which means that we bring patients to the OR even though they have still some disease, but we want to do the surgery anyway. So we bring the patients to the OR and we reassess the disease through laparoscopy before laparotomy. And the second reason is that we participate to the Lance trial. So we start with laparoscopy because we believe that if we can complete surgery with MIS approach, we continue with MIS.
Well, I think the time is over.
Yes.
We thank you very much.
Thank you.
We thank you for your time. We really appreciate it. And I hope that we can have you here in Mexico in person. So thank you very much.
I hope to have you in Europe sometimes.
For sure.
Okay.
Unfortunately, I cannot come to the Czech Republic next week, but eventually we will go there, and I hope we can meet some other time. Thank you very much, Ana.
Thank you. Bye-bye, everyone. Thanks a lot.
Thank you. Muchísimas gracias a toda nuestra audiencia. Ha sido una gran charla. Agradecemos a todos su presencia. Nos vemos aquí muy pronto en nuestra próxima masterclass. Y buen día para todos.
Bye.